This video will provide you with instruction on a procedure for obtaining the ankle brachial index and Doppler waveforms for the diagnosis of peripheral arterial disease. Peripheral arterial disease is a common manifestation of atherosclerosis in this country, affecting 8 to 12 million Americans. This disease, though quite prevalent, is underdiagnosed and undertreated, and as a result, these patients suffer a high risk of cardiovascular events, heart attack, stroke, and death. In addition, this disease is responsible for a significant amount of disability. Detection of peripheral arterial disease is critically important, and there are several well-established therapies used to reduce this risk and treat the disability. The first step is a proper diagnosis. A patient history of intermittent claudication and abnormal pulses in the physical exam alone are insufficient to make a diagnosis of peripheral arterial disease. Therefore, the medical community has turned to the ankle brachial index, which is the non-invasive gold standard for the diagnosis. This video will provide you with instruction on how to perform the ABI as part of a bilateral single-level lower extremity arterial assessment. The LifeDop 250 ABI is the premier handheld Doppler for performing the ankle brachial index, or ABI, exam for the diagnosis of peripheral arterial disease, or PAD. The system includes a bidirectional handheld Doppler and portable high-speed printer. In this section, we'll show how to set up the system and perform the ABI examination, including Doppler waveform acquisition and documentation that is required for reimbursement under CPT 93922, the exam code for the single-level bilateral lower extremity physiologic study. Setting up the system is simple. Remove the Doppler and the printer from their packaging. Plug the coiled cable into both the probe and the Doppler main unit. Press the button to turn the Doppler on and off, and use the slider to adjust the audio volume. The LifeDop 250 ABI printer is supplied with paper already loaded. To turn on the printer, press and hold the printer on-off button for 3 seconds. The printer LED will flash green when the power is on. The printer cable plugs into the side of the Doppler unit and into the side of the printer. Both ends of the cable are the same, and the cable is labeled to show which side of the connector is up. Press the lever gently to unplug the cable. Prepare the patient for the exam by having them take off their shoes and socks. Ask the patient to rest in a supine position for about 5 minutes prior to taking pressure measurements. You may use this time to discuss the patient's current symptoms, explain the exam, and wrap the blood pressure cuffs. The ankle brachial index is the ratio of ankle systolic pressure to brachial systolic pressure. In healthy patients, the ankle pressure is similar to or slightly higher than the brachial pressure. When PAD is present, there is a pressure drop associated with the stenosis that results in a lower ankle pressure. The ABI exam is fast and simple to perform. For reimbursement as a single-level lower extremity exam, Doppler waveforms are required. It is important to use the proper size pressure cuff. Summit supplies cuffs in 10 cm and 12 cm widths. The proper cuff width is 40% of the patient's limb circumference. For limbs with circumference less than 28 centimeters or 11 inches, use the 10 cm cuff. For larger limbs, select the 12 cm cuff. Most clinicians have found that wall-mounted blood pressure cuffs do not work very well for vascular testing due to the lack of mobility and because multiple cuff sizes are often required. The most efficient way to conduct the ABI exam is to wrap all 4 limbs prior to taking the first measurement. This enables you to move quickly from limb to limb and minimize the elapsed time between pressure measurements. A 4-cuff package with aneroid is available as Summit Doppler model number K170. Be sure to avoid rolling up sleeves or pant cuffs in a manner that could obstruct blood flow. Place the cuff 1 to 2 inches above the Doppler site. Avoid placing the cuff too high on the calf, which could result in false, high-pressure readings. Prepare the cuffs for use by plugging the hose into the aneroid. Plug the other end into the cuff prior to use. The arm pressure is taken at the brachial artery. Here we'll start at the right arm. Apply gel over the brachial artery. Position the LifeDop probe on the site at 45 degrees with respect to the artery and pointed toward the incoming blood flow, in the general direction of the shoulder. Slowly move the probe laterally to find the arterial pulse. Make small adjustments to obtain the loudest arterial signal. Avoid pressing too hard, which could occlude the flow. Depending on the patient, you may hear some venous sounds alone or in the background while listening to an arterial signal. Venous flow will not interfere with the blood pressure measurement because the vein will occlude at a relatively low pressure as you inflate the cuff. Before inflating the cuff, be sure to brace your probe hand. Inflate the cuff quickly, stopping about 20 millimeters of mercury above the occlusion pressure. Squeeze the inflator's trigger gently to deflate the cuff at a rate of approximately 2 to 3 millimeters of mercury per second. Note the point at which the first blood flow sounds return. This is the systolic pressure. Afterward, deflate the cuff fully. Record the pressure on the report form and then repeat this procedure on the left arm. Now we'll move to the right ankle. Before inflating the cuff, we'll acquire the Doppler waveform required for reimbursement. It is important to record the waveform before inflating the cuff, since flow dynamics may be temporarily altered after occlusion. In this example, we'll acquire a waveform from the posterior tibial artery. Later, we'll discuss using the dorsalis pedis for the ankle measurements as an alternate site. The posterior tibial artery is located on the inside of the ankle. Maintain a 45-degree angle and move the probe slowly across the artery to obtain the loudest signal. Point the probe toward the incoming flow, in the general direction of the knee. This is a triphasic signal from a healthy patient. Observing the signal bars will help you to visualize the flow. Flow toward the probe, in this case forward flow, is shown by bars to the left. Flow away from the probe, reverse flow, is indicated by bars to the right. This is typical of a normal triphasic waveform. Note the forward, reverse, forward sequence. Waveforms taken with the probe near 90 degrees will be diminished in height. Be sure to use an angle close to 45 degrees and point the probe in the direction of incoming flow. Here is an example of the probe pointed in the incorrect direction and the resulting waveform. Although it's tempting to press down to try to get a better signal, the extra pressure could partially occlude the vessel, so be sure to use only very light pressure. Again, note the correct probe position and orientation at the posterior tibial artery. Once you obtain a good Doppler signal, wait at least 4 seconds for the buffer to fill. A good guideline is to count to 6 to ensure the memory is filled. Then, press the red button on the side of the Doppler to store the waveform. The waveform will print automatically as soon as communication is established with the printer. The printer is exceptionally fast, and the waveform is scaled automatically to fit the paper. With the LifeDop ABI, you won't need to repeat the test due to improper scale settings. Avoid turning the Doppler off before printing a waveform from memory. Stored waveforms are deleted when power is turned off to prevent any confusion later. Only the most recent waveform is retained. The old waveform is overwritten when you press the red print button. Remember that when you press the red print button, you're selecting the 4 seconds of waveform prior to pushing the button. When the button is pressed, the data is sent to the printer immediately if the printer is connected and ready, or stored until the printer is available. The LifeDops display will show STR when a waveform is stored and PRN while printing. If you press the button before collecting 4 seconds of waveform data, the memory may not be filled. The resulting waveform might look like this. Record the patient and site information on the waveform to prevent confusion later. After obtaining the Doppler waveform, proceed to take the systolic pressure at that ankle. Locate the vessel again and brace the hand to stabilize the probe. Inflate the cuff to about 20 millimeters of mercury above the occlusion pressure. If the Doppler probe comes off the vessel during inflation, deflate to 0 and try again. It may take a few times to learn the technique. Gently squeeze the trigger to deflate at a rate of 2 to 3 millimeters of mercury per second. Listen for the first blood flow sounds to return and note the pressure, then rapidly deflate the remaining pressure. Record the right ankle pressure on the report form. If the ankle pressure is significantly higher than the higher of the 2 brachial pressures, the artery may be incompressible due to calcification. The pressures should be reconfirmed, and other diagnostics should be considered if the high ankle pressure is repeatable. Follow this same procedure for taking the waveform and systolic pressure at the left ankle. As an alternative to the posterior tibial artery, ankle measurements can also be performed at the dorsalis pedis, or DP. The DP is found here. Maintaining the proper 45-degree probe angle can be more difficult at the DP. Although many of our customers prefer to use the posterior tibial artery, sometimes the DP will provide a stronger Doppler signal. And pressures from both arteries should be obtained if the patient is suspected of having a tibial arterial occlusion, thromboembolus, or has undergone a tibial bypass. Here's an example of improper technique. Angles like this should be avoided. Remember to use the proper 45-degree probe angle. Now we are ready to complete the LifeDop ABI report form. When calculating the ABI, always use the higher of the 2 brachial pressures. If the difference between the 2 brachial pressures is 20 millimeters of mercury or more, recheck the brachial pressures and consider further upper extremity testing if the variance is repeatable. A variance greater than 20 millimeters of mercury between brachial pressures could indicate an upper extremity occlusion. For both sides, divide the ankle pressure by the higher of the 2 brachial pressures. Summit provides a convenient chart for determining the ratio. Later, we'll discuss interpretation of the ABI. Complete the report by peeling the back off the waveform labels and attaching them to the form. The single-level lower extremity physiologic study combines the diagnostic value of the ankle brachial index with Doppler waveform analysis. The normal Doppler signal is pulsatile and multiphasic. Here is a set of normal waveforms from the posterior tibial artery. The systolic acceleration and deceleration are rapid. These waveforms are triphasic with 2 diastolic components. Waveforms from patients with disease will be diminished. Notice the waveform height is less than 1 kilohertz. With moderate to severe disease, the signal will become monophasic. There is no diastolic component. The weak signals associated with diminished flow produce waveforms that are more jagged in appearance. The waveform's rise and fall times lengthen as disease progresses. A long deceleration is a sensitive indicator of PAD. Here is a set of waveforms with the characteristics of abnormal posterior tibial flow. The acceleration and decay times are slow, the diastolic components are absent, and the waveforms have somewhat diminished height. These waveforms are typical of a patient with moderate to severe arterial disease. Here is another set of abnormal posterior tibial waveforms. The key characteristic here is the slow decay. Also, note that the reverse flow component is absent. These waveforms are associated with mild to moderate disease. The characteristic of waveforms acquired at the dorsalis pedis are similar. Here are examples of normal DP waveforms. This waveform is biphasic. The second forward flow component was not detected. Now that you have learned how to obtain the ABI value, we would like to assist you with the interpretation. Typical normal values range from 0.90 to 1.30. Results above 1.30 suggest that the vessels in the ankle are not compressible. This can be seen in patients with diabetes and end-stage renal disease. In this situation, please send your patient to a vascular laboratory to continue the diagnosis using other tests. The threshold for disease is an ABI value of 0.90, and lower ABI values correspond to more severe hemodynamic disease. Below 0.90, there is a high degree of certainty that the patient has PAD, and the Doppler waveforms will begin to show characteristics of disease. Please initiate prevention therapies and consider these patients as high risk for future cardiovascular events. The following section includes information on the care and maintenance of your LifeDop 250 ABI system. Always refer to the user's manual for complete information. Clean your LifeDop system periodically using Transeptic or another alcohol-based agent. Summit Doppler Systems recommends against using cleaning agents with detergents since they may eventually degrade plastics. The red paper edge indicates the paper is about to run out. Loading new paper is easy. Pull up lightly on the lever beside the paper cover to open the paper compartment. Drop in a roll of paper with the leading edge positioned as shown. Close the paper compartment. The LifeDop printer uses rechargeable batteries. Low battery indication is provided by the LED. The LED flashes green and red when the battery is low. The printer recharger plugs into the left side of the unit. The LED turns red to indicate recharging. We recommend unplugging the printer prior to use. See your printer manual for additional error codes provided by the printer LED, including out of paper or open paper cover. You can test the printer's operation by performing a printer self-test. Conduct the test by holding down the feed button while turning the printer on. The self-test begins with a distinctive checkered pattern. The printer must have paper loaded and a charged battery to perform the self-test. To replace the printer's rechargeable batteries, open the battery door and release the secondary latch. Note the proper battery orientation. The battery label will be on the bottom. The LifeDop ABI's battery door is on the rear. Be sure to note battery orientation. The two on the side are inserted plus side down. The one in the center is plus side up. See your user manual for additional instructions and special precautions.